Hello, everyone. Welcome to today's speaker series. Thank you all for joining. My name is Rosa Stalteri. I'm the Knowledge Translation Manager with CanCOVID and also the speaker series moderator. It is with great pleasure to welcome Dr. Emily Marshall, who will be discussing her findings from the PUPPY study, which is a study that builds on existing research and works to understand critical gaps in primary care access and coordination by comparing data from before, during, and after the pandemic. Dr. Marshall is an associate professor in the Dalhousie Department of Family Medicine Primary Care Research Unit, also cross-appointed in psychiatry, and is a mixed methods researcher. So before I hand over the floor to Dr. Marshall, there's just a few items we note before every presentation. We ask that you have your microphones on mute during the presentation, but you can leave your cameras on if you wish. Also, you can ask your question at any point in the chat box during or after the presentation, or raise your hand if you'd like to ask your question live. And finally, our sessions are posted on YouTube in about 2 to 3 business days. So without further ado, I will hand over the floor to Dr. Marshall.
Thanks for the introduction, Rosa. It is a pleasure to be here. I'm going to start with gratitude for being able to speak to you from the ancestral and unceded territory of the Mi'kmaq people. As a descendant of settlers and Métis peoples, I feel grateful to be able to live and work on this land, and we are all treaty people. I'd also like to thank Susan Law for this invitation to speak with you. Having listened to many CanCOVID presentations, I'm honored to be amongst such a wonderful, committed, and bright group of researchers. I'm also dedicating this presentation in honor of Dr. David Gass. He's the former head of our Dalhousie Department of Family Medicine who passed away on Friday. David was a wonderful, encouraging mentor and a great supporter of research. I will miss him tremendously, as will so many others whose lives he touched. But without further ado, I'm now going to talk to you more about our PUPPY study. So some of you may be familiar with primary care, and for others of you, this may be a new area of study. So let me tell you a little bit of background. More than 85% of healthcare visits are to primary care providers, primarily family physicians and nurse practitioners, and a growing scope of primary care offerings from registered pharmacists. Strong primary care has been shown to have better results for health outcomes, reduce disparities, and lower spending. Primary care can address the social determinants of health, and I would argue is an underutilized resource for surveillance for things like long COVID. Primary care could help overcome vaccine hesitancy, and primary care was impacted by COVID-19, and we need to know how it was impacted and to what end. So I'm going to share a little information on how are we doing pre-COVID in primary care in Canada. Just recently, the Commonwealth Survey was released for 2020, and you'll see a few graphs here where Canada is highlighted in the orange bar. So you can see that that same day and next day appointments were very difficult to get in Canada compared to other Commonwealth countries. And that while patients had difficulty accessing after hours care, physicians actually reported offering after hours appointments. So there seems to be a disconnect and an access challenge there. Canadians were less likely to receive a same-day callback from their physician compared to the Commonwealth average. And almost half of Canadians reported that the condition they visited an emergency department for could have been treated elsewhere, such as in primary care. More Canadians waited longer for specialist appointments and elective surgeries. We're bottom of the pack on this one. But before you get too sad, when we do get access, more Canadians reported good experiences with their regular doctors compared to the Commonwealth average. So I would argue that we have wicked problems in primary care. And by wicked problems, I mean ones that are difficult to solve because of incomplete, contradictory, and changing requirements that are often difficult to recognize, solutions that aren't true or false, but better or worse, and where wicked denotes resistance to resolution rather than evil. Some of the problems in primary care are that more than 15% of Canadians don't have a regular primary care provider or place of care. Among those with a regular source of primary care, many still struggle with access and availability. We are the first country we know of to implement centralized waitlists for primary care attachment. And a lack of access is eroding public confidence in our healthcare system. We also see a rise of for-profit access, which has costs for individuals and no accountability in our system. I would also argue that primary care is undervalued in our system. It currently has the lowest prestige and pay, which then becomes a challenge for recruitment. Primary care providers are also reported to have the highest rates of burnout. And prior to COVID, primary care change was incremental, required negotiations with multiple sectors, and was impeded by risk aversion and cost containment. COVID brought a sea change that requires study. Virtual care in particular represents a radical transformation of both how care is delivered and remunerated, but also how quickly these new modalities, payment structures, liability issues, training needs, and so on were implemented. The pandemic has flipped the narrative, and that requires study. Radical transformation happened. Did the sky fall? Where did it shine? And what aspects need further change or refinement? So I've talked a little bit about some of the challenges in primary care. There's also challenges in conducting primary care research. The first is that primary care is a really complex arena. Primary care involves many different types of providers, many different remuneration methods, from fee for service to variable contracts that are different across all the provinces, and also different models of care, from that traditional solo doc who works with an administrative person to manage their practice, all the way up to large interprofessional collaborative care teams with many different kinds of providers. There's also lots of different data sources for trying to understand what's happening in primary care. A common one that's used are administrative healthcare data. These are relying on provincial billing codes for those fee-for-service docs and the shadow billing that may exist for nurse practitioners and family doctors. These are often incomplete. It's also challenging to access these data. They're often time delayed, costly, and in some provinces, they're not available at all. We can conduct chart reviews. These require permissions from the clinics where you want to collect the chart reviews, somebody who has a good amount of experience to know how to read a chart and interpret the data, and it can cost a lot of money. Surveys are a great way to collect data generally, but unfortunately, healthcare providers tend to provide very low response rates to surveys, even when they come from their own provider organizations. Qualitative data is incredibly rich, but also contextual. And so it can be challenging to know how to scale that up into interventions to support primary care. Electronic medical records are probably the field where you have the most amazing potential for learning health systems and surveillance. So the Canadian Primary Care Sentinel Surveillance Network, originally funded by FAC, lost their FAC funding a number of years ago, and they've been trying to kind of stay alive across the country for a number of years. And now there's another threat aside from having sustained funding, which is that EMR vendors are creating financial barriers to being able to access that electronic medical record data for research. This situation has been resolved in some other countries, like in the UK and in the United States, by creating federal legislation that protects that data for research purposes. I think this is one of the most important issues facing healthcare research in our country. And if you're interested, the College of Family Physicians of Canada is doing really important work and is published on this area. And I highly recommend you get involved and advocate for our access to this data for primary care. So now that you know a little bit about the challenges in primary care and primary care research, let me share a bit about our puppy study and how we've tried to design this research to mitigate those challenges. So our puppy study is cross-jurisdictional, interprofessional, and has a multi-provincial team, many of whom have long-standing relationships of working together. We're using multiple modalities of data collection so that when we answer questions using one data source, we can sort of help understand and contextualize that information and see how it plays out across the other ways that we're going to collect data and from different types of folks. We also have a robust integrated knowledge translation plan that started from the inception of the grant and will carry right through so that our information can become as useful as possible for the people that need it the most as quickly as possible. So for the PUPPY study, we're particularly interested in equitable access to healthcare. Healthcare access is defined as the opportunity to have healthcare needs fulfilled. And as you can see in our adapted Levesque model, it's influenced by accessibility of providers, organizations, institutions, and systems on the one hand, and then the ability of those individuals, households, and communities and the population to access primary care. And as we described in our grant that was funded by CHR, both sides of this equation have had a COVID-19 anvil dropped on their capacity to provide and access primary care. As policy changes rapidly emerged, COVID-19 was also anticipated to cause delays in foregone care, as well as increased mental health needs of providers and patients, as depicted in this graphic that was published fairly early in the pandemic by Tseng. It's vital to understand how COVID-19 impacts primary care to inform urgent concerns and the future of primary care, and that was the impetus for the PUPPY study. So the PUPPY study objectives are to identify primary care policies and interventions impacting primary care attachment. And this is conducted through policy scans in each province and qualitative interviews with policymakers and healthcare providers. We're also going to try and understand how COVID-19 affects patients' experience of accessing primary care, considering needs and demographics, and also provider health and well-being. And these will be done through qualitative interviews, and then we will use those interviews to develop surveys for following up. Then we want to examine healthcare utilization, attachment, and primary care providers, and prescribing as indicators of access to primary care, both before and during the pandemic. And we're doing this through linked administrative healthcare databases, including the centralized waitlist data in the 3 provinces. And then we're going to share our promising strategies to provide access to primary care with all of those who can help us make a difference. So now I'm really excited to get to some of the emerging findings. They'll start with the qualitative. I'm going to read through the text on the left of some of the key emerging findings. You can read the quotes on the right while I talk. So we know that we've seen major shifts for decision makers, providers, and patients, and people talked about things like flying by the seat of our pants and doing our best to try and respond to COVID. There was a real sense of duty and obligation to provide service to patients and community. And also people talked about how that citizens also wanted to do their part to help. There's a major shift in triage, virtual care, referrals for lab tests, imaging, diagnostics, sourcing PPE, and all the processes that come with managing COVID in a clinic. We've seen delayed patient care and primary access challenges, increased mental health concerns for patients and providers. And we also learned that gender is playing a real role where women seem to be having additional challenges. Provinces varied quite a bit in their response and coordination for access to care and how to support unattached patients. All of the provinces and territories shifted to virtual care, suspended non-urgent services such as screening, labs, and imaging, as well as surgeries, and restricted visitor support persons as part of their COVID-19 response. Reintroduction of services was gradual and not synchronized, and novel systems were created. So in Nova Scotia, you can now use 811 as a telephone line or do online bookings for things like blood work, diagnostics, COVID tests, and so on. And in Nova Scotia, we had family health teams in each zone provide interim primary care access for patients who were waiting on our centralized wait list. From family physicians, we heard that it felt like the real focus of attention for policies was initially on emergency and acute care. There was a worry that we'd overrun the hospital systems. And so they sort of felt a little overlooked at the beginning of the pandemic. Physician information overload and burnout during the first wave was very common. Patients perceived family practices were closed, and in fact, in Nova Scotia, very few closed, and most added options for virtual care, but patients seemed to struggle with understanding how to access care and whether they should. Family physicians largely saw patients seeking care for complex concerns, so people might have been waiting to come in, and patients reported delaying access to care because they were afraid of getting exposed to COVID. Rapid implementation of practice changes were stressful, confusing, and sometimes hard to keep up with. And there were differing impacts of these changes based on gender and payment models. So if you were fee for service and fewer people were coming for appointment, that directly impacted your income. Virtual care implementation was discussed extensively. There were challenges emerging from virtual care, such as the speed of the adoption, concerns about confidentiality and access. There was also a vision for opportunities for primary care and positives that were relayed. Some people felt this was really convenient, it gave more timely access to care, and it increased the capacity to take on new patients for some providers. That was not the case for all of them, but some did say it gave them more capacity. And providers often asked, to what extent should virtual care be used? It was unclear when it would be most appropriate, and then would fee codes appropriately compensate the work. And last of these qualitative findings are on the increased scope of practice for pharmacists. So there was this big shift right before COVID, where pharmacists in Nova Scotia had major increases to their scope of practice. And patients clearly viewed pharmacists as an accessible provider group that was easier to access than other sources. Pharmacists experienced significant burden. They also acknowledged having some communication challenges between themselves and other providers and services with all these new changes to how they practice. Pharmacists had to manage innovation and scope of practice expansion, and also negotiating their expanded scope of practice versus patient needs, because sometimes patients still wanted things that weren't part of the services they could offer. And now I'm very excited. We've had some centralized waitlist data in Nova Scotia for some time, but yesterday we got some more data. Thank you, Health Data Nova Scotia. We got more data for our administrative billing data. So I'm going to walk you through just a few slides of what we've just gotten access to. So here you're looking at our centralized waitlist data, and the through line on the bottom is from January 2018 to February 2021. And on the top, you can see some important dates. So the first date is when an attachment incentive was put in place to take on patients from the centralized waitlist. And then you see when the first wave began, just happened to coincide with when that incentive was being taken down. And so you can see how many people in that orange line each month were being taken off the centralized waitlist. The blue line represents those who were being added to the list, and the bottom line just tells you the rates of COVID we had in Nova Scotia. I'm going to focus just on the top part of the slide here, where you can see the number of primary care visits from January 2018 through December 2020. And you can see that there's a general slope of declining numbers of primary care visits in Nova Scotia. And here you can see the primary care visits divided up over time from January 2018 to February 2021, where the blue line is the regular primary care visits. The orange line that's below denotes the number of what used to be called remote, and now it's called virtual care visits that were taking place. And the gray line is when you add those two together. So you can see a bit of those trends and what happened with the emergence of COVID in Nova Scotia. These are the virtual primary care encounters. And so there's some interesting things around the proportions by age in terms of who's getting access to those virtual visits. They always existed, but they're clearly happening a lot more now. And lastly, here are the virtual specialist encounters. And so it's interesting to see the major drop off. And by December 2020, it didn't seem to recover very much. Some very interesting patterns for gender and age that we're looking forward to digging into. So I've just gone through those findings from the quantitative, so I'm going to skip that because I know I'm running out of time. And just let you know, we have a lot more work to do on the puppy study across the 3 provinces we're really excited about. I want to thank my amazing co-PI team and all of the other partners that we have associated with this research. And I look forward to your questions.
Thank you so much, Dr. Marshall. It was nice to see the results of both the qualitative and quantitative research. So thanks so much. It was really informative.
We were really excited to have it to share.
Yes, absolutely. So we have about one question in the chat box. I don't see any hands up right now, but maybe perhaps we can give the opportunity to your co-PIs if they want to add anything that wasn't discussed, and then we can go straight to the questions.
Yes, anyone who from our team who's on the line, feel free to speak up or put something in the chat.
Okay, so maybe we'll get started with the question first. So the question is, what can be done to address communication accessibility needs better in virtual primary care? So in this, this is referring to some of the limitations, for example, physicians denying requests of people with hearing loss to use video conferencing options and instead using phone calls, which were insufficient for communication. So maybe perhaps you can touch a little bit upon that.
Yeah, and it's a really good question that I don't specifically have the answer for yet. We are going to be starting our interviews with patients about their experiences in the next phase of the study. Other people might have other suggestions, and I know that there's a call to actually look at issues of equity and access to virtual care. So I suspect there's going to be a lot more research coming out about this because that is a major concern, especially for people in rural communities or with various disabilities.
Perfect. So we do have a hand up. Steve Slade, whenever you're ready, you can ask your question.
Thanks. Thanks, Emily, for a great presentation, and thanks for remembering Dr. Gass at the outset. So I have a question. You've sort of showed some of the metrics of how family medicine took a hit, and I do wonder about the future of family medicine and the impact of fee for service. I mean, it was maybe not the best model of care, and it's certainly proven to be a very vulnerable model of care, vis-a-vis the sustainability of primary care services. But really, the big question I have, and what I wonder if you've looked at in your study, I find it so, I don't know if I'm surprised or just dismayed that primary care had really nothing to do with the tracking of infectious disease at the outset of this thing. That we have a system where, the digital infrastructure is not connected. You couldn't really track. People stayed away from their clinics, and then they probably could have connected with patients and been a source of, where is infectious disease happening. And now that we're rolling into sort of the vaccination stage, it's all sort of happening as best it can. I take that, but really you can't triage patients using primary care systems where you would say who are the most vulnerable, those with chronic conditions, and how could we actually get vaccines to people that really are perhaps most in need of it, and in ways that you are sort of systematically, mining that information out of VMRs and stuff like that. So I wonder if you've looked at that at all, actually, sort of the role of the primary care system in a go forward kind of let's do this better in the next pandemic.
Yeah, I think I think I've asked that question in many other CanCOVID talks about why are you using primary care? And I think SIPSN as a network has an incredible opportunity to be able to step into that role of trying to get a sense of how many long COVID cases are there and what are the symptoms and the trajectories and the treatments, and how are vaccinations doing and how much vaccine hesitancy, and can we develop programs to help support the uptake of vaccinations. So I think primary care has a really strong role to play. One of the answers I got from another presenter was it's really complicated because it's run provincially and it's hard to create a national plan for that. But I think we can do it. We've come together as a nation through all of this. And I think we're learning that we really need to understand this for the sake of the patients, the system, and the healthcare providers who also need to be supported in all these new roles. So I would love to see us using, especially being able to back-end abstract EMR data from primary care. It would be incredibly rich across the country.
Thanks so much. So the next question is, can you speak a bit about your own ideas to explain the age and gender trends you mentioned?
So the gender one, I think, is no surprise to many folks. I think we still have some very gendered roles and responsibilities that exist in our society, despite our mothers and grandmothers working hard to try and break some of those down. And I think we also have pay gaps. So even if the gender roles are different, if people have to make choices about who goes to work, you often want your higher breadwinner, and unfortunately women still get paid less than men. So I think there's a lot to be said there about how we have work to do on gender equality. And then in terms of age, I think that you have different healthcare needs as you age, and they're more complex, and you have different capacity to access the different systems. A lot of the things we have put in place are incredibly useful. Like you can go on a website and book things and look at stuff, but not everyone has access to being able to use virtual care. And I also think that care for the elderly, if they have complex needs, is sometimes less conducive to a virtual visit. So then figuring out how you can help people. And then there was this article today that just came out around how do we get vaccinations to people who have a hard time getting to vaccination locations. So I think we have a lot of work to do around equity and access, and maybe not just about age, but about having multiple chronic conditions that require more complex care needs.
Great. The next one is, and I think you touched a little bit upon it, but we can ask the question again. Did you look at differences between solo physicians versus physicians who are part of teams? What role is family medicine playing in the vaccination process in Nova Scotia? In Ontario, it has been sidelined until now.
Right. So that is one thing we have learned. We've been very fortunate in Nova Scotia because our COVID rates have been much lower, and our restrictions sort of had remained higher to help with that. And we had some other natural advantages, I think. And it's been much more challenging in some ways to collect some of the data that we're looking for in Ontario and Quebec, because they just had a very different ability to recruit people to participate in interviews. But it's happening, and we're getting great data. We are using family physicians. I don't know if we're using them as much as we could. And in Nova Scotia, hardly any family physicians have had access to vaccination yet. They really have focused on long-term care and acute care settings. So I think there could be better integration with primary care. It's complicated with the different systems. So you have one group that are salaried and another group of folks who are fee for service. So figuring out how you would roll those out. But I personally know a lot of physicians who've been volunteering their time, getting vaccinations at the clinics, and like when they hold the big centers where people can come. We're going to know a lot more about that as our data collection continues, but I don't have a lot more to say about it yet. Other people on the line, though, might know more than I do.
Thanks so much. So the next one is, are you going to be able to access any quantitative data regarding pharmacist visits and activities during the pandemic? And also, it was great presentation, Emily. So just wanted to
thank you. I think I have a friendly audience. Yes, so I have to tell you, linking up with this group of pharmacists in the 3 provinces has been magic for me, because they are actually providing an incredible service, and they're in all these communities, and another great resource for how we can manage things during a pandemic and just generally, and how we work together across these professions is going to be really important. So we do have data on all the prescribing in Nova Scotia that is occurring with pharmacists and other healthcare providers. So yes, we are going to be looking at all of that data.
Great. And so we do have just a few just regular comments. There's a review by Croda outlined issues like domestic violence, more women quitting their jobs, more housework taken on by women, among others. And there's a link to the research there. And it looks like we're at 4:30, and I don't see any more hands up. So I think we can close here, but I just wanted to say, Dr. Marshall, thank you so much on behalf of the CanCOVID team and network We'd like to thank you for your time to present on this informative and timely research to us in our network. And I'm really much looking forward to the rest of the results from this study. And just to note, we hope to see you all next week at our speaker series, which is on the same times on every Tuesday. And next week will be March 30th at 4 o'clock. So thanks, everyone. And thank you again, Dr. Marshall.
Thank you.
Bye.
Take care.